I'm Lindsay Patterson, Interim Director of Scottish Health Action on Alcohol Problems, and I'm chairing today's event. SHAP is a partnership of the Medical Royal Colleges in Scotland and the Faculty of Public Health, and we are based at the Royal College of Physicians of Edinburgh. I'm also welcoming you here today on behalf of the co-chairs of Scottish Alcohol Research Network, or SARN, who are Professor Aisha Holloway and Professor Carol Emsley. And SHAP and SARN have been supporting this lunchtime alcohol occasionals seminar series for, I think, 8 years now. And the purpose of these seminars has always been to help showcase new research and early career researchers and just kind of share innovation on a wider scale. And the events really just provide a chance for people from many different perspectives to come together, whether it's research, policy, or members of the public, just to hear about alcohol-related topics and to discuss policy implications from the discussions that happen at the seminars. And after the event, we will produce a briefing paper aiming to capture the main themes and to communicate these to a wider audience. And there will also be a video on our website and YouTube channel. So the theme this year for the seminars has been alcohol inequalities, and they've been a really successful series of seminars with great participation. And because obviously we're on Zoom and using kind of remote technology, it's offered us a chance to kind of reach audiences who would not have typically been able to attend our alcohol occasional seminars. So we've had delegates joining us from Nepal, Uganda, Brazil in previous sessions. And I'd just like to encourage you, wherever you are joining us from today, whether in the UK or further afield, if you would like to share, please put a message in the chat telling us where you're joining from and your interest in the research that we're hearing about today. And our speaker today, Wendy Masterton, is going to be addressing the topic of green space programs for problem substance use. And we are delighted to welcome her to the Alcohol Occasional series. Wendy's currently in her final year of PhD based at the Salvation Army Centre for Addiction Services and Research at the University of Stirling. And she's undertaking a realist evaluation of green space programs for improving mental health and supporting people with problem drug and alcohol use. And her research interests are in realist methods, substance use, harm reduction, mental health, and the health benefits of green space and green space interventions. So just before we hear from Wendy, I will just cover a few final housekeeping points. For those who have been joining through my introduction, please note that the webinar is being recorded, and please turn off your video if you don't wish to appear in any of our social media or post-event materials. We will be covering this event on social media, so please take a look at the thread on our SHAP Twitter account, or you can use the hashtag alcohol occasionals. And all participants in the webinar will be automatically muted throughout the presentation, except for our speaker. And you can pose questions or comments relating to the presentation through the chat function on Zoom. And after the presentation, I'll use these to bring in individuals into the discussion. And of course, we will then be having questions and responses from the floor to enable some wider discussion. So we're very much looking forward to hearing from Wendy, and I will hand over to you now, Wendy. Thank you.
Great, thanks, Lindsay. I will just share my screen. Right, could someone just let me know if that's sharing? Okay. Perfect. So yeah, thank you for the introduction, Lindsay. It's a real privilege to talk here for the last Alcohol Occasionals event that's planned before the break. So as Lindsay said, I'm a third year PhD student at the University of Stirling, and I look at how green space programs might be used to support people with the problem of substance use. So my work is not just specific to alcohol, and a lot of the work that I'm going to talk about today actually relates to both alcohol and other drugs. And my PhD is also not looking specifically at inequalities, but I'm quite interested in the link between green space and inequalities and how that could link to reducing inequalities for people with problem substance use. So this is what I plan to cover in today's webinar. So the first thing I'm going to do is give a really quick overview of green space and pathways for health. So I think this is quite important to provide context of how green space is related to health. I'll then discuss the association between green space and health inequalities and the intersection between green space, health inequalities and alcohol use. I want to discuss that despite there being quite limited evidence actually in this field that green space availability could reduce inequalities and specifically in relation to alcohol use. So I'm then going to talk about how green space programs, rather than just the quantity of green space, could be used to address inequalities relative to alcohol. And then going to talk about a potential framework that could aid implementation of programs for people with problem alcohol and drug use, and discuss some of my work in this area. I'm then going to finish by talking about enduring inequalities for this client group and finish with some takeaway messages. So I'm going to talk for maybe 45 minutes, so there'll be plenty of time for questions afterwards. So firstly, I want to cover what green space actually is. So there's two broad interpretations that are present across the literature. So in some circumstances or some instances, green space can be used sort of synonymously with the word nature and used to describe any type of natural or semi-natural undeveloped land. And the other use of green space is used to describe any type of vegetated land within or in the immediate outskirts of an urban area. So sometimes this is referred to as urban green space. And in the Scottish Government's planning advice note for planning an open space, there were 23 separate types of space identified as a sort of type of green space. So they could potentially be used instead of the term green space. So you can imagine that unclear definitions can lead to confusion. And there's some researchers that say that when you talk about green space or you undertake green space research, you really have to clarify what you mean by that term in each study. That's the only way to ensure explicit understanding. So with this in mind, in this seminar today, I'm going to use the term green space as an umbrella term when referring to all types of green spaces. So whether it's in an urban environment or in a rural environment. And when I talk about specific types of green space or green space programs, then I'll specify and describe these. So I want to really quickly take you through some of the proposed pathways of green space and human health. I'm going to come back to these a bit later on, but I want to provide a bit of context here, as I think that's important to aid understanding. So the first pathway is the idea that green space reduces harm through ecosystem services. And what I mean by the term ecosystem services is the benefits that humans gain from nature and ecosystems. So quickly, two examples might be air oxygenation, so in other words, cleaner air, or climate regulation, for example. So these are like the indirect benefits that humans get or are said to gain from nature and green spaces. And then the next pathway is the idea that time spent in green space restores capacities. So the two leading theories in this, in regard to this, is attention restoration theory and stress reduction theory. So attention restoration theory proposes that nature or immersion in nature facilitates mental restoration, and this improves well-being. Whereas stress reduction theory holds that engagement with nature allows changes in psychophysiological processes. So this leads to reduction in psychological stress and physiological arousal and negative effect. And then the third pathway is about building capacities. So there are two main pathways that are proposed here, physical health and mental health. So in regard to physical health, availability of green space has been reported as an important resource for promoting active engagement, for example, through physical activity and active travel. But then, as well as building physical capacities, green space can be utilised to facilitate mental health outcomes. So it's really important here to highlight that none of these pathways are isolated pathways. There's a lot of interlink between them, especially with mental health, really notable interlink between all the pathways together. So I'm going to come back to talking about green space and mental health more specifically later in the presentation. But what I want to focus on first is this general evidence for green space and its role in reducing health inequalities in general. So a recent rapid scoping review of health and well-being that was commissioned by Natural England showed some evidence that green infrastructure, so this is the idea of building with nature or integrating nature into planning and development, has a positive influence on population and individual level health and well-being, and is associated with less stark inequalities in health. But the idea is not new. And Rich Mitchell and Frank Popham published quite a well-known paper in The Lancet in 2008 exploring the effect of exposure to natural environments on health inequalities. And what they found was that health inequalities related to income deprivation in all-cause mortality, as well as mortality from circulatory diseases, were lower in populations living in the greenest areas. And their takeaway message was that environments that promote good health might be crucial in the fight to reduce health inequalities. And I'll draw on some of their work in a wee bit as well. But one of the newest systematic reviews published this year by Alessandro Rigolon and colleagues explored the potential inequalities, and what they found was people from more deprived areas gained more health benefits compared to affluent people, particularly when concerning public green spaces and parks. What was interesting, though, was that they found that this was much stronger in Europe compared to the States, which starts to suggest that context matters. So, for example, the authors suggested that systemic racism and police harassment and discrimination experienced in parks in the United States could play a part, or Europe's public healthcare systems might push some countries to invest in more upstream health interventions, or perhaps green space is higher quality in Europe's lower socioeconomic neighbourhoods compared to the States. So this idea of lack of or poor quality green space can actually further affect inequalities. So, for example, in another study by Nam and colleagues, they concluded that tree canopy was 17% lower in the most deprived areas in areas of the United States compared to the least deprived, and exposure to airborne carcinogens was 3 times higher in the most deprived areas compared to the least deprived. So how does this all link to alcohol? So going back to what I briefly said at the start, there's actually very little research exploring this, but what I'm hoping to do is explore how this idea of green space mitigating some of the health inequalities experienced by people with problem alcohol use is feasible. So firstly, we need to think about the link between alcohol-related inequalities and lower socioeconomic status. So we've seen from global data that people in richer countries are more likely to drink alcohol and overall have higher rates of consumption. And Scottish and British data also show that those in more affluent areas are likely to drink more alcohol or the same amount as people in more deprived areas. But this doesn't mean that the harms from alcohol are less in deprived areas. In fact, it's the opposite. So Jennifer Boyd, who spoke here at Alcohol Occasionals a couple of months ago, she spoke about this idea of the alcohol harm paradox, the idea that those in more deprived areas tend to experience greater alcohol-related harm than those of a higher socioeconomic status, even when they drink the same or less amount of alcohol. So if you have somebody in one of the most deprived areas drinking the same amount of alcohol compared to the least deprived, then that person in the deprived area will experience far more harms, including ill health and early death. And in Scotland specifically, alcohol-specific deaths are 7 times higher in the most deprived areas in Scotland than the least deprived, and alcohol-related hospital stays are 8 times higher as well. So if I draw back on the example I gave a few slides ago of green space and reducing health inequalities in those with a lower socioeconomic status, Rich Mitchell and colleagues identified that socioeconomic inequality in mental well-being was 40% narrower among study respondents who had good access to green space compared to those with poor access. But also what was interesting is that no other neighbourhood characteristic was in their study was associated with reducing health inequality. And also their study was based on data for 34 European nations. So it was quite a large study from different areas as well. And this idea of the features of the environment acting to create health equality within the confines of existing material inequality is referred to as equigenesis. And what is further interesting is that time spent in green space appears to be more beneficial for those in more deprived areas compared to affluent areas. And this has been shown by quite a few studies now. So taking this and relating it back to alcohol, if people with a lower socioeconomic status are at a higher risk of alcohol-related harm, but if green space is successful in reducing health inequalities for people with a lower socioeconomic status, then it's feasible to suggest that green space could be a protective factor in mitigating some of the health inequalities experienced by people with problem alcohol use in more deprived areas. But as I said, the issue being that there's actually very little research of that intersection at the moment. But looking more specifically at mental health, there's a well-documented link between mental health and alcohol use. Some people drink alcohol to cope with previous trauma, poverty, existing trauma, and challenging life circumstances, for example. There's evidence that suggests that stress and distress of COVID has led to higher levels of alcohol consumption in some people as a way of coping. Despite using alcohol to cope with stress and poor mental health, on the other hand, alcohol use can also exacerbate mental health challenges. So again, thinking back to the presentation when I first introduced the pathways, evidence shows that green space allows decrease in stress and improvements in mental health. In a recent study by White and colleagues, they found that people who spent at least 2 hours in nature per week were consistently more likely to report higher levels of health and well-being compared to people who spent less time in nature. But what was perhaps most important in this study was that the pattern of a 2-hour threshold was present for nearly all groups that were looked at. So older and younger adults, men and women, people in cities, rural areas, people in deprived, people in wealthy communities, even people with and without long-term illness and disability. So what this suggests is that the results are not merely due to reverse causality. So the idea that people who visit nature are already a self-selected sample of healthier people, because even those with long-term illnesses were more likely to report better health and well-being if they spent 2 hours a week in nature. So there's a vast number of studies that now show a link between green space and mental health, both in the UK and internationally. Research has explored the relationship between green space and mental health in lots of different domains, as I've written on the slide here. So subjective well-being, depression, anxiety, general mood, self-esteem, and others. In Scotland specifically, the Green Health Project was designed to explore the relationship between green space and mental health. And one key finding of this study was that people who lived in urban areas and who used green space such as woods or forests for physical activity had a lower risk of poor mental health than people who did not use these green spaces. But also use of outside areas such as woods and forests appeared to be more effective in improving mental health than use of the gym when doing similar activities. Excuse me. From the international literature, so in some parts of Asia, for example, like Japan and Korea, the concepts of forests being healing environments is really ingrained in their culture, with the idea that through immersion in forests, stress is reduced and well-being increased. So this is referred to as forest bathing or Shinrin Yoku, and is actually growing in popularity here. So you may have heard of it and you may have experienced it yourself. But what's been shown is that green space is in fact more beneficial for people with poor mental health compared to those with positive mental health. This has been shown in various studies, looking at walking outside in rural compared to urban areas, green exercise in different environments, and various other green health activities. So if green space improves mental health, particularly for those with poor mental health, could there be a subsequent effect on the use of substances? So if green space improves health, could there be a preventative effect on substance use? So just to recap over the last 4 slides, overall alcohol harm is higher for people from lower socioeconomic backgrounds and for those with poor mental health. If green space is shown to contribute to health, particularly from those from a lower socioeconomic background and those with poor mental health, then it seems feasible to suggest that increasing opportunities for engagement with green space could play a role in mitigating harm and reducing health inequalities for these groups. So how does exposure to green space actually reduce inequalities in the first place? So in a paper by Beck Lovell and colleagues that explored improving access to green space, the authors discussed the ways through which green space could promote positive health and well-being outcomes. So the first thing they spoke about was physical activity. So this is linked to positive health outcomes of many types. Green space can support higher levels of physical activity. There's indications that people may enjoy and more likely to repeat an activity if it takes place in a natural setting compared to inside. The National Institute for Health and Care Excellence suggests that green space should be used whenever possible to support people of all ages and all abilities to undertake physical activity and improve their health and well-being, and reduce the need for direct, more costly interventions. And then secondly, recreational activities. So the activities that people do in green spaces, not necessarily high activity like physical activity, but even things like enjoying the scenery or walking the dog or relaxing, has been shown to positively impact mental health. And evidence is really still evolving in this area, but there's indications of positive impact of outdoor recreation, including things like improved self-perceived competence, things like learning and identity, positive well-being, and increased family cohesion as well. And then nature connection. So some evidence indicates that people who feel more connected to nature tend to have a more positive outlook on life, increased vitality, increased life satisfaction, feelings that life is worthwhile, and of personal growth compared to those who feel less connected. And then community and social cohesion. So reviews have shown that green space can reduce isolation and the loneliness by providing the opportunity to participate in shared social activities. Again, this leads to greater social cohesion, in turn leading to better mental health. And then finally, mediating potential harm through ecosystem services or ecosystem benefits. And as I spoke about earlier, these are the passive benefits of green space for example, things like air oxygenation, noise reduction, even climate moderation. These are all things that affect health, and evidence shows that greener areas are linked to higher levels of ecosystem benefits. However, of course, there are potential barriers that may limit these mechanisms, particularly for people with problem alcohol use, for example. And I'm going to come into that a bit later on as well. But for now, I want to talk a little bit about green space intervention programs. So as well as availability of green space, so things like walks in the park and general immersion in nature, another way green space is used is through green space programs. And what I mean by a green space program is a health intervention typically undertaken outside in a green area. So other terms can be used, for example, green space intervention, nature-based program, nature-based intervention, green health program, for just a few examples. And green space programs can provide a range of social and health benefits. There tend to be three basic types of interventions. So firstly, those that increase the amount or quality or improve accessibility to green space, those that increase use of or engagement with natural environments, and thirdly, those that use targeted health interventions based in green space. And it's really this third type that my work focuses on. So for these more targeted health interventions, many settings have been used, for example, public parks, woodlands, rural settings, private gardens, allotments, community gardens, farms, and others. From a mental health perspective, they incorporate many factors that allow a person to effectively build capacities in factors such as social cohesion and interaction, self-efficacy, learning new skills, for example. So I'm now going to talk through just three common types of green space programs. There's lots of different types though, and many green health organisations will use a variety on their programs. So therapeutic horticultural programs, they're seen across the UK, commonly undertaken in specialised gardens within residential care, hospitals and rehabilitation facilities, for example. And the gardens offer people a chance to participate through therapeutic hands-on green activities and by spending time in green space. And they also provide a supportive social environment and this chance to build relationships in what is being referred to as a non-threatening atmosphere. And wilderness and adventure programs, they typically utilise larger areas of green space. Interventions are often residential programs, often developed for adolescents and young people, as a way of sort of promoting recovery through removal from high stress or chaotic environments. And it's this feeling of kind of being away, that as well as learning new skills and the restorative effect of nature. They're often reported by participants as being particularly important factors in the success of these programs. And then care farming is the use of regular farming activities to promote mental and physical health. These are usually based on a commercial farm or actually any other type of agricultural landscape. It's estimated there's over 240 care farms in the UK, over 8,000 people using them for some type of support. I would have thought that numbers have probably increased over the past year as well, potentially. The range of support that Care Farms provide runs on a continuum between just passively providing a therapeutic environment and providing more structured programs. So like I said, these are 3 examples that I've given that are seen across the UK. But green space programs can also be community-based groups, things like health walks, for example, green gyms, football groups, conservation groups, etc. There's a really wide range of activities that can go on and can be called green health. So Green Health Partnerships in Scotland, funded by NatureScot, have developed various green health referral pathways that enable green space programs within the community to contribute to primary prevention and the maintenance of both physical and mental health. And participating in these green health programs, I guess, transforms the common approach to prevention and treatment and recovery of ill health. It can also improve treatment success in people who have already developed mental health issues and help with their recovery. So this is a diagram showing how this idea of green space and green space programs, referred to in this diagram as nature-based interventions, can complement the NHS to achieve health outcomes. So you can see in this flow diagram that shows how green space can be beneficial within the general population, as well as for people with a more defined need. In some parts of the UK, a formal pathway has been developed alongside the medical prescribing pathway to connect NHS primary and secondary care with nature-based interventions through this green health prescription pathway. So a physical prescription is given to suitable patients to connect them with local nature-based programs. Patients receive this person-centered consultation with a dedicated green health worker to find an activity that is most suitable for the service user's need. So this picture on the slide is an example of a green prescription from Dundee. And in Scotland, green prescriptions have been implemented so far in Dundee, Edinburgh and Shetland for a variety of different conditions and different client groups. So how can green space programs for substance use reduce inequalities? So they can be used with a prevention focus with young people who have a higher risk of substance-related harm. For example, Young People's Wilderness Adventure projects. Organisations such as the Venture Trust, Venture Scotland, among others, have worked with young people, not just with a focus on substance use, but using a holistic approach to support them with their lives. And green space is really central to their work. And green space programs can meet people where they're at. So one of the key benefits of green space programs as an intervention for people with problem substance use is that they can provide support for people without placing any demands or expectations on them. So many programs typically don't require abstinence, or they don't require a commitment to reduce substance use. Of course, some programs do, but many don't. So this could improve access onto programs or access into support. And often the programs are supportive without falling under this typical banner of treatment, which potentially removes the stigmatization and medicalization that can sometimes be seen relative to substance use treatment. So they can also run alongside other substance use services. For example, Phoenix Futures have their Recovery Through Nature program, which runs as part of their wider support. So it's really important to note here that green space interventions don't claim to be a panacea, but they could be a feasible addition to a package of holistic care and could signpost to other specific substance use and or mental health services. While there's an increasing number of green space programs that are being developed, there's still actually a limited understanding of the key components and the processes that actually go into making these programs successful. And this makes it quite difficult to develop and implement new projects or new programs and evaluate them successfully. Also, a better understanding of the processes within a program may increase the likelihood of engagement with programs from a client's point of view, interest in programs, but also buy-in from stakeholders, those working in primary care, for example, like GPs, who may be the ones actually referring clients in circumstances like green prescribing. So the question really becomes, what are the mechanisms that lead to the outcomes? And this is where my work is situated. So for the first phase of my PhD, I undertook a review of existing literature and used a realist approach, which in comparison to many evaluation types is not about focusing on if something works. It's instead about creating program theories about how interventions are meant to work. So realist approaches hold that outcomes of interventions like green space programs are achieved through underlying generative mechanisms, which are present in the right context. And I've used this word mechanism quite a few times in my presentation so far, but what I mean by it is that it's the causal aspect within a program that leads to the outcomes. So I guess it's the why an outcome happens. And these responses are influenced by context. So the factors that make responses more or less likely to happen. And context can be individual, interpersonal, organizational, institutional, within the program setting. So a realist evaluation establishes causality between a program and an observed outcome by focusing on this context mechanism outcome configuration, which is also referred to as a program theory, which is literally the theory about why a program works. And each program and intervention is made up of a number of program theories, which are refined through the evidence provided in the data. So this area of work is developing all the time, and there is actually a lot more evidence than now than when I did it a couple of years ago. But when I undertook the review, there was quite limited empirical evidence regarding green space programs for supporting people with problem substance use. So the review actually focused on green space programs for mental health more generally in clinical and non-clinical populations. And what we then planned to do was develop program theories and a framework for these programs, then at the next stage, test it to see if it was also applicable for green space programs that support people with problem drug and alcohol use. So in the review, 49 full-text articles were synthesized. Ongoing conversations with green space organisation staff was held throughout the search and appraisal process. And using the data, the context and the mechanisms and the outcomes were combined into 7 program theories. And the 7 program theories were combined under 3 themes of nature, individual self, and social self to provide a sort of overarching theory or framework. So we found that there were 3 themes, as I've just mentioned, that all the components seem to fit into. The components that to do with nature, which are the red row, components to do with changes in a person's individual self, which is the yellow row, and components to do with the wider social self, so things like the grey row. So things like changes in peer relationships. And the program theories are listed on this graphic as numbers PT1 to PT7, but the titles are fully explained in the paper, which I'm going to link to at the end so that you can see the graphic just in a little bit more detail than you can see on the slide. But the first program theory was looking at the feeling of escape and getting away from daily stressors. Program theory 2 was having space to reflect. Program theory 3 was increased physical activity. Program theory 4 was increased self-efficacy with new skills. Program theory 5 was having a purpose. Program theory 6 was about relationship with the facilitators. And program theory 7 was about shared experiences within the group. And it's these headings of the theories that I think really show what some of the kind of key aspects are in regard to green space programs. And it's these mechanisms in the middle column. These are said to be, I guess, the key ingredient, if you were, that leads to outcomes as long as they happen in the right context. And these are the components overall that we found make green space programs successful for mental health. So some of the things that lead to outcomes in relation to nature quickly are the feeling of being away from daily stressors, connection to nature, and time alone to reflect. Some of the things that lead to outcomes in relation to the individual are enjoyment of activity, self-efficacy, feelings of purpose, feelings of routine. And then some of the things that lead to outcomes in relation to social self are trust in others, decreased power inequality between the facilitator and client, feeling safe within the group, and shared experiences. But these are really just some of the mechanisms that lead to these optimum mental health outcomes. There's also additional influencing factors. I've not included this on the slide, but they are in the wider model. So again, if you are interested, then I'll provide the link at the end and you can have a look at that. So how does this relate to alcohol and other drug use? So what we then did was to take the framework forward to see if it was applicable with programs that support people with problem alcohol and drug use, and therefore show that mechanisms that lead to beneficial outcomes, so then programs can be effectively developed for this client group. But what justification did we have to do this? To answer this, you really have to think about the link between mental health and substance use, which I spoke about very briefly earlier. The link between mental health and both drug and alcohol use is well established with previous systematic reviews and meta-analyses reporting a strong association between the two. So the question becomes, if green space can improve mental health, then could it reduce substance use or at least support people with problem substance use through similar causal mechanisms? So the second phase that was looking at if the framework also works for programs that support people with problem substance use. And there are successful programs that exist for this client group, but actually, again, very little understanding of the causal pathways. So we distributed a survey to green space organisations in Scotland to test the framework in the study before, and basically ask participants to what extent they agreed with the framework components. So there was responses from 55 organisations from 10 different regions in Scotland, which is actually fairly high. All programmes supported clients to improve or maintain their mental well-being. Approximately 36% of programmes supported people with problem alcohol and illicit drug use. Just over 39% did not support people with problem substance use of any kind. There was a wide variety of types of green space used, so some were urban, some were rural. And results showed a really high level of agreement overall with the framework in all organisations, including those that supported people with problem substance use. So what this means is that the framework seems to be applicable to both green space organisations specifically for mental health, as seen in the review, as well as green space programmes that support people with problem substance use. So this framework could then inform future programme implementation. So we've written this up as a research paper and it's currently under review. So what I want to talk about now is some of the evidence from the green space programmes directly themselves, people that work on the green space programmes. And this is the work that I've done with interviews in phase 3 of my project. And the aim of this phase was to further test the framework. But what I want to try and do today is show a little bit about how health inequalities could be addressed by these types of programmes. So in terms of my method, I conducted qualitative telephone or Zoom interviews with staff on green space programmes, researchers within the field, and relevant wider stakeholders, so people involved in green health partnerships, green prescribing, and other people whose work is related to green health. I interviewed 12 participants in the first stage and then interviewed 5 participants in the second stage of interviewing. In realist research, this is referred to as a consolidation phase, so the final testing of the framework. And I wanted to interview clients on the green space programmes, but many programmes were stopped because of COVID, and I wasn't able to work on the programmes themselves. And even the ones that were open, ethically, there were issues there because there were limited spaces, limited places, and strict social distancing measures. So me being on a programme would take the place from somebody else who could be on the programme actually benefiting from it. So this is work I really hope to do in the future, because it's really important to me to include clients' voices, but that's why it's not involved. That's why it's not part of this this study. Unfortunately, I think that's a really important thing to kind of get across, like why they're not involved. So I just want to read through some of the findings in regard to reducing inequalities. So in relation to reducing inequalities relative to the community, some of that community stuff, feeling valued, feeling part of society again for the first time, perhaps in 20 or 30 years, that is directly related to being outdoors and utilising that green space down at the allotment. To come from such a stigmatised, sort of isolated, lonely place of serious addiction to actually feeling just part of the community that you live in through the gardens is absolutely amazing to see. And taking part in these types of things, they then start to feel quite a bit of pride in the community. They feel as if they've got something to offer. They sort of value themselves a bit more than they originally did to begin with. They're feeling included. They actually feel like they belong to something, so they feel like they matter all over again. And in relation to access to services or service approach, when you're outside, there are less agendas or less pressure. I think when you're sitting and you're talking in that setting, when it's a one-to-one setting and you've got 2 people sitting opposite each other, they're in a chair, they're in a room, it could sometimes be a bit daunting to open up. I think part of that is about the garden being a non-medicalised environment where you're not using the labels that are given to people around whatever their mental health challenges are. This is the other thing about gardening. They're all in it together and we're all learning together. That kind of is a nice way, that is kind of a way of neutralising power dynamics. And I think is a really nice space for people that often feel like their voice isn't heard a lot in their day-to-day. In comparison with clinical appointments where I've met people in an office environment for around 45 minutes or an hour, it's the natural setting, the reduced sense of the power balance really between the professional and the clients. It felt like a much more equal footing for the client to attend. And then in regard to relationships, so relationships were mentioned a lot by interviewees, which is probably not surprising. So we don't ask people to do stuff. We do stuff with young people. So if we're building a raft, we're all building a raft. If we're going to jump off something, we're all jumping off. It's that equal, that level playing field where we try and level up the client facilitator thing, involving them as much as possible and allowing them just to take ownership of the actual journey that they're on, rather than just being, kind of like a boot camp type thing where they're there and they're kind of told what to do. And we come at it the wrong way. We try and get the person to stop doing something that they need to do without replacing it with something that might tick the same box. Where I guess the idea of green space programs, it's like, let's just do some stuff and get connected and build relationships, build huts, build bivouacs, do what you like. But fundamentally, what you're really doing is building connections and building relationships to the point where if you do it long enough, the substance use might take care of itself because other things have taken its place. So for the last part of the seminar, I want to talk about green space and sort of ensuring inequalities. So if you think about the fact that nature and green spaces are free to use for the most part, they're around a lot of us, and there doesn't seem to be any reason why people can't use them. So is access actually equal? And I'm sure you won't be surprised to hear me say that they're not, and current provisions of green space are not equal. Those who may benefit the most, for example, people with problem drug or alcohol use, are often at disadvantages in terms of both access to both quantity and quality of space. So, for example, the availability of green space differs depending on where you live. Affluence can allow people to buy homes that in areas that have got more green space, better air quality, more space for physical activity. But while there are many green spaces in some deprived areas, overcrowding can be an issue. It's often seen at a higher rate in deprived areas. This means that the number of people who are potentially using each available green space is higher compared to more affluent areas. So even if there is green space, there's more people using it. Crime levels and litter, for example, could be issues. And inequalities in access to green space actually became even more apparent during the COVID-19 lockdown. And one study highlighted that around 13% of people in England and Wales live more than a 10-minute walk from their local park. So when walking in local parks and other green spaces was deemed essential for mental health during the pandemic and lockdown especially, those that live a distance away are at clear disadvantage. And another recent study by Hannah Burnett and colleagues in Glasgow showed that use of green space reduced during COVID, possibly due to a number of reasons. For example, people who were anxious about leaving home, particularly those who were shielding. Also, those who were working frontline possibly had less time to visit. Women and older adults were less likely to visit green spaces too. So you can see that there's really kind of enduring inequalities there in terms of people and access and people who can access it. And also, while green infrastructure can reduce inequalities in health, it's likely over-reliant on the assumption that green infrastructure is equal across communities, which isn't the case. And furthermore, poorer quality green infrastructure can actually exacerbate inequalities. There's also evidence that new or renovated green infrastructure can actually exacerbate inequalities as well through processes such as gentrification. So green space and green infrastructure can actually make communities more expensive, which negatively affects the people who live there. So this sort of goes against the idea of a win-win idea of if you increase green space, then you increase health or reduce inequalities. So it's not quite as straightforward as some of the things that it might seem. And inequalities in access are also seen relative to specific green space intervention programs. So programs are designed to improve health outcomes, but attending these programs can be reliant on practical but often overlooked aspects that can create barriers. For example, particularly for people with problem substance use. So examples include the cost and the ease and the safety of travel, the cost of owning the correct clothing and footwear, particularly since COVID and no longer being able to share or borrow items, things like caring responsibilities, physical capabilities and general differing personal circumstances can present inequalities as well. So mobility issues may limit people's ability to take part in more physically demanding programs. Wilderness projects, for example, might not be appropriate for people who've been involved in offending and have an electronic tag, for example. And even things like court dates should be taken into consideration to ensure that the programme doesn't affect these. Medication and treatment needs as well have to be taken into consideration, those on a daily pickup prescription or those undertaking a detox, for example, then it's probable that a number of these types of programs are not going to be suitable for them. Also, wilderness projects might not be appropriate for people with certain conditions, for example, psychosis. So previous experience is also a potential barrier, which may mean that some people are less likely to take part. So some people that have had less experience with nature or being outside in nature have been shown to be less inclined to take part or being interested in programs. So they may require somebody to go with them, so like a support worker or a buddy to go with them. So this actually happens across Dundee in the Green Health Partnership scheme there. Also, if a person has negative experience with treatment services or have been let down by safeguarding, then this could affect their engagement as well. So if a person has negative experience and has been let down by the care system, the criminal justice system, other health services, then why would they trust another programme? So programmes really have to work in a trauma-informed way to address this and ensure that that isn't just a buzzword. But more positively, here are the sort of key messages, I guess, from my work. So the integration of green space into mental health strategies could be important, given that mental health concerns are increasing, which suggests a need to find ways to support the rising demand while limiting rising costs. So they could have a prevention role, something that there's quite a lot of interest in just now with rising substance-related harm. But they also have the potential to meet people within the communities and where they're at. So whether they've got a goal of reducing their alcohol use, for example, or whether that's not their goal, the support is there in lots of different areas. These types of interventions can fit into wider policy landscapes, and the climate agenda, for example, increasing or maintaining green space is essential in the fight against climate change. They can run during COVID when many other services had to shut. Interesting, the BPS updated their guidance about outdoor talking therapy quite recently, which shows this move outdoors within more mainstream services. And as I hope some of the quotes showed, they can reduce key inequalities, for example, in relation to improving engagement with services, reducing stigma, improving relationships, and integration back into the community. But what is essential to take from this talk, in my opinion, is that these interventions are not a substitute for care. They're part of a holistic care, and they can potentially allow outcomes which other treatments don't, whether that's changes in relationships, empowerment, reduced stigma, reduced power imbalances, on top of the therapeutic effect of nature itself, such as the feelings of escape or stress reductions and a connection to nature. But as I mentioned previously, they're not a panacea for all. And I think that this final quote really represents this idea quite nicely. So I'll just read it out. I like the idea of these programs contributing to wider systems of care. So they are not seen as the thing you do now, and then something else will come up at the end. You know, they're part of a package of care to whatever degree they need, and it contributes to care rather than it is the care option. So that's me. Thank you for listening to my presentation. Here are my contact details, my email address and my Twitter handle as well. Also the link to the Realist Review with the framework, and it goes into it in a lot more detail than I was able to in this presentation today. And also the link to a conversation article that discusses green space and health inequality.
Thank you very much, Wendy. That was a really, really interesting presentation. And I mean, I feel I've absorbed a lot of information from that. I think, you know, as you were saying, particularly with the pandemic and, you know, increased awareness and use of outdoor spaces and so on, I think green space kind of as a whole has been, you know, really brought into focus, and obviously the benefits of using green space as well. But, you know, your kind of takeaway message was, I thought, you know, really, really important. And some people have kind of picked up on these sorts of issues in the chat, that I suppose green space, you know, the use of green space itself is part of a solution rather than the kind of be all and end all. And I think that's something that that we can definitely explore, and you know, in terms of equality and access to green space too. So I think Yeah, there's a lot to talk about here, and thank you to those who have been contributing in the chat as well. I noticed we've got lots of different professionals who are interested in different aspects of health and care and policy in the chat, and we have people joining us as well from India, Afghanistan, Pakistan, and Nepal today. As well as I'm sure many others. And in the UK we have from Cumbria and Derbyshire, as well as I think there was somebody maybe from East Lothian, although I could have, oh no, someone is from East Lothian, yes, as well. So there's lots of different kind of perspectives in our audience today. I suppose actually I would quite like to kick off because we do have a range of people who attend our alcohol occasionals. Are there, kind of professionals in the audience, or indeed kind of clients or patients who have benefited from using a green space programme? Has anyone actually been using them in practice? If anyone has, put up your hand. Oh, I see Magda's put up her hand. Magda, would you like to contribute?
Hello, yeah, it's just I'm actually working for Access to Industry, and we've got a gardening project. We work with people who suffer from addiction and are in recovery, and we actually had a garden. Now it's shut because of the COVID, and it is because it's on the community center, so we cannot actually access it. But we had yearly gardening project, and it was brilliant. It was very successful, and a lot of people experience that effect that you mentioned, Wendy, that they really felt the sense of belonging, and they had this identity that has been raising their self-esteem, and actually they felt really they felt part of a sort of community, and they learned something as well, because we had a garden and that actually taught them some information about how to grow vegetables. And so I would definitely say that it's very beneficial, and we're really suffering now that we cannot access this garden at the moment.
And Magda, just can you tell us again where you're based?
I'm based in Edinburgh, and we actually, the Braidwood Centre is the centre that we use. It's in the city centre in Damidykes area, and there is a community centre that unfortunately, apparently, council didn't allow to open yet, so we cannot actually access it at the moment.
Okay, that's really interesting. Thank you. And I can see a lady. I'm afraid it only has iPad as your name, but I thank you. Would you like to contribute?
Hi there. Sorry, I realised it just said iPad. My name's Maggie, and I'm from East Lothian. We have 2 community growing spaces within our organisation that, I see huge benefits to many of our clients who come with many issues, because nobody comes with one issue. There's always a myriad of reasons why somebody has an addiction problem or social isolation problems, and definitely with the effects of COVID, when we really tragically had to work behind locked garden gates, we found that our regular clients and people were coming to us, and reporting that they were going back to, making sort of different choices from what they had been doing, and were maybe returning to old coping mechanisms and behaviours that they didn't want to, because they weren't having that social experience, they weren't having that outdoor experience, they weren't having that sort of sense of reward that they got from being within the garden spaces. And they're not always gardening when they're there. Sometimes they're simply being, or they're talking, or they're feeling just in a safe and supported environment. So I can definitely see the merit of it daily.
Thanks very much, Maggie. That's really good to hear about that initiative. So just thinking about Wendy's presentation, are there any particular questions that people would like to pose? I can hear a bit of an echo. I don't know if everyone, I think that's helped, thank you. Who would, I'll ask Alistair McGilchrist, who is the chair of SHAP, if he'd like to pose a question.
Thank you very much. Enjoyed your chat, Wendy. I'm sorry I missed the start of it, and my question relates a little bit to what the previous speaker, Maggie, was saying. Could you quantitate the benefits in a way that, is there a difference between, if you like, just the passive provision of a green space and a green space where they actually are involved in activities, but be it gardening or maintaining an allotment or whatever? Or can you show that just providing the space is enough, or do you need the activity as well?
I mean, I think that that's something that will be very individual to a person. So there's research that has been done that suggests that having the green space and just providing the green space is not enough to really have a big impact in changing people's behaviours. What I would say is that I guess it depends on the reason why that person is using the green space. So, for example, if somebody just is feeling quite low in mood and they go out, they can take themselves out for a walk, you know, as many of us do, and that is enough to make them feel better. They don't necessarily need somebody to be guiding that through them. But if you're talking about people with, you know, problem drug or alcohol use, for example, then if they've got more sort of challenging sort of circumstances or more complex situations, then there is evidence that the sort of the facilitator or the led group is more effective in terms of achieving some of the more sort of specific outcomes. I would imagine that just immersion in nature would have beneficial effects. But if you're looking to sort of achieve these sort of optimum outcomes, then as I sort of drew on in my framework, that idea of like relationships within the social setting, so like peer relationships within the groups, but also the relationships sort of building trust and sort of power inequalities with the facilitators of the programs is very important as well, and something that you wouldn't get if you were just kind of individually going out into the green space.
Thanks.
Thank you, Wendy. Can I take Diane next? Diane, would you like to ask a question? You're on mute, Diane, I think.
Okay, thank you. Yeah, I'm a patient. I'm actually in recovery from addiction. And so I would say that having access to nature, being in nature, it makes sense of life. It also brings peace. I should have known what PSUD meant. No, I do. If you are sort of suffering from problems with substance abuse, I call it abuse. I know you're not supposed to call it misuse. I actually call it abuse. It's very, very difficult to get peace, and I think that nature can give you peace. You talked, Wendy. There was a phrase: experience to natural environments and mortality. And what hit me was not about if you have less, you know, maybe death comes sooner to you. It's also that you kind of understand death, because in nature you see death, you see everything happening in nature, and I think it's just it just brings a whole different feeling to you if you can experience nature on green spaces. Mm-hmm. So, thank you.
Yeah, absolutely, Diane, and thank you for your comments, because that is certainly something that's come through in the interviews that I've done. So people talking about how clients on programs, they feel that there is that sort of reduced rumination, you know, and there's time to just kind of be. And I guess that draws on that on the program theory on space to reflect. So just space, you know, that kind of physical, but also like psychological space just mm-hmm. to like reflect on your life, mm-hmm. Which is really powerful. And then also drawing on what you were talking about, the metaphors. So that's something that comes through from a lot of people talking about, they see the process of life and death within nature, and the ability to actually kind of think about that in terms of their own life, and also some of the challenges, not just necessarily life and death, but some of the challenges of tending to plants and tending to live organisms, you know, that so it's not always straightforward. There are challenges, and that sometimes you have to put more care in something, or they're lacking sunlight, or they're lacking water, or they're lacking food, you know, and you learn how to like care for something, and then in a way realize that how that relates to your own life. So absolutely, I completely agree with you, and thank you for sharing.
I think also you feel useful, you feel you're contributing, whereas you may have felt useless before, you actually get doing something now which is helping. And so I think it was very, 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 very nice to hear your presentation, Wendy. Thank you.
Thanks, Diane. And Jill, can I come to you next?
Hello, Wendy. Thanks very much for your presentation. I was wondering, you were mentioning at one point that it was all boiling down to making connections and doing stuff alongside and making connections and building relationships. And I wondered to what extent, when you were doing the review of your literature and in all your engagement with all the different green space programs, what your feelings would be about the longevity or the importance of longevity of connection and the program. And Brian Duncan and I are from Branching Out South Aberdeenshire, and we run a 12-week program as a standard Branching Out model, and then we have a Branching Out Plus program to which all previous members of our Branching Out programs are welcome to join. So that community is ever growing, and I just wondered whether you had, what your feelings were about the longevity of that connection.
So I think that the longer a program is on for, the more likely it is that clients will buy into it, will develop develop relationships. And one of the things that did come out is that social relationships are sometimes quite difficult for people to make, particularly for the client groups that we're talking about, for people with problem alcohol or drug use. And so a program that's longer will be more beneficial in that sense. But it's really challenging because a lot of green space, if not all of them, are kind of short-term funded. So that's a real challenge, and I certainly don't have the answer to that, because it's something that was brought up time and time again in the interviews that that was a real barrier, because not only for the clients themselves who they might be put off by a program only being there for a few weeks. And I was speaking to somebody who she said that a lot of the clients that she worked with would say, I just wish that I could keep going on this program. I just wish it was going on for a longer amount of time, because in reality, it's 12 weeks long enough. And actually 12 weeks is a long green space program. There's plenty of them that are only kind of 4 weeks. But also in terms of the staff, how can you expect staff to buy into programs and want to be part of programs that are only going to be around for, a very, very short term? So I think that there are real challenges there, and how we get around that, I don't know, but I completely agree with your point in terms of longevity and how important that is for the program themselves.
Thanks very much, Wendy and Jill. I also noticed actually in the chat, I think it was Jennifer Lang was saying that once people do start going, attending the program, people continue coming back. There's a good retention rate, and I think that just is kind of reflected there, that after 12 weeks, and it ends. People are, I suppose, kind of disappointed that it's ending because they've enjoyed it and found a benefit from it. So I will go first to Serge and then to Maggie again. So Serge, would you like to go now?
Hi, thanks Wendy for your wonderful presentation. I would just like to piggyback on Diane on what she said earlier. I'm also a person in recovery, and I went to treatment. I'm from the Philippines, by the way. And I think I am one of the recipients of green space, because my treatment facility is up in the mountains here in the Philippines. So it's cooler and has more trees rather than in the city. And I think after a while, or after 6 years in recovery, I opted to go up to the mountains again and settle here. And I think that's green space. I have some couple of questions, because I'm also in my master's. And since I'm a person in recovery, what is the vulnerability of people with substance use disorder capitalizing on green space and planting opium, marijuana, and cocaine? Because there's definitely going to be a trigger with that. And then it was answered a while ago that green space cannot be standalone. Is there a link on green space in relation to sustainability for the ecosystem? Probably that can be an avenue towards the future, that it can be, people can be taught in order to have a sustainable livelihood through green space. And lastly, isn't green space more appropriate for the aftercare rather than the intensive or the primary care component of treatment? So those are just my questions.
Okay. So the first question that you had in terms of planting, I guess that could be something to take into consideration. It's certainly not something that I've encountered here, but again, maybe the context is different. I made that comment at the start of the presentation that context really differs between, for example, the States and Europe. I would imagine that the Philippines, for example, would differ from some of the literature that goes on here. What I would say is if that was like a trigger in terms of like planting things, then green space programs, as I mentioned, there's lots of different types of them. So perhaps for that person, a gardening program would not be something that best met their needs, and perhaps they would enjoy like a forest program, or even like a wilderness program, which focuses on different activities than ones that potentially would trigger them. So I would say one of the important things to consider is just doing a sort of like needs audit, when somebody comes onto the program, to ensure that you know about these sorts of things before embarking on activities. So yeah, I would say that just providing a variety of activities is really important, and that should enable people to choose activities that don't trigger them in their recovery journey. In terms of your second question and linked to sustainability, absolutely, as I mentioned at the end, one of the benefits of green space programs in a sort of with a much wider lens is that they do meet kind of like climate agendas and some of the wider policy landscapes. And even thinking about some of the work that people were doing on green space programs and talking about the clients on the programs, many clients have learned the skills to then take that into their own lives. So for example, planting or growing their own vegetables, or taking part in more conservation or positive conservation activities. So there's research that shows that when you interact more with nature, you start to care more about nature. So the more people that are kind of involved in green space programs, or involved in kind of in nature, or taking part in various things in nature, then potentially that will have a knock-on effect in their activities outside of that. So in terms of even like recycling or some of the kind of wider environmental behaviors. So yeah, absolutely, it can link to sustainability on a wider scale. And then your question about it makes sense afterwards, then I mean, absolutely, I don't think that I personally think that it could be very beneficial in all parts of recovery, because what it can offer you, it offers like new skills, it offers that potential for social cohesion, it offers that kind of maintenance of peer relationships, and as well the benefits of just immersion in nature. I think that can be very powerful as part of a treatment approach to substance use. Like I said, running alongside other treatments. I think it's really important that in the majority of circumstances that it wouldn't be a standalone program, it wouldn't be the only source of treatment. But I think that afterwards it still provides these things, it still provides this really kind of powerful mechanisms that can potentially maintain a person's mental health, which can obviously be very beneficial. What the challenge is that, do we have the problems with funding, or challenges with funding the programs themselves. So actually, how do we then ensure that funding is continued afterwards? Because we're very focused on the interventions themselves, but what about like kind of afterwards? Mm-hmm. So I think that there needs to be more work there, as there does in lots of different treatment approaches. It's certainly not just about green space programs. I mean, that's kind of it's relative to lots of different programs. So I think that's really important, but where we are with funding, I think that's a real challenge for that.
Thank you very much, Wendy, and thank you for joining us, Serge, from the Philippines as well. Thank you for joining our meeting today. So I'll come to Maggie and then to somebody McDonald, perhaps. I'm not sure, but Maggie first.
Hi again. I'm not quite as exotic as the Philippines here in East Lothian. I have a couple of questions around staffing, which I think Wendy, you called facilitators. I know within our setup, if you like, our staff in the gardeners are gardeners, and they provide a kind of mentored support, and most of our staff kind of come from a community and social justice background, and they have a empathy and a compassion. And I was just wondering, did you find when you were speaking with any of the facilitators, as you called them, at any of the other programs, that they felt that there was enough support for them to personally develop, to feel secure that they were in the advice and support that they were giving? Do they get, I know for the likes of us, we provide supervision for our staff teams if they need extra support, if they're, are involved in any sort of safeguarding issues or disclosure or any of that sort of thing. So what's the kind of protection and CPD for the staff to ensure that they're rolling out the best that they possibly can for themselves and for their clients? And I was also wondering, and you may not be able to answer this, I don't feel that you have to, in terms of the Green Health partnerships, which I can see that are absolutely fantastic, but how do we as a country get further buy-in from other health and social care partnerships to officiate that and to spend their money? Well, I know that we get socially prescribed referrals from our primary care services, but there's no money that follows that. And I know funding isn't your study here or whatever, but was there ever in your research and all the stuff that you looked at, was there any sort of discussion around is there half a dozen local authorities or health and social care partnerships that have bought into this Green Health partnership? That seems really sad when the evidence is so starkly producing information that, stacking the benefits of this sort of work.
Okay, so I'll answer your first question first in regard to the facilitators. So just briefly, the reason why I call them facilitators is because I felt that staff sometimes didn't actually cover who were sometimes running the programs, because a lot of the programs are very reliant on volunteers, and they're not staff. And also in some programs, there's a real focus on people within the group actually leading the programs. Again, they're not staff. So when I was writing or when I was kind of undertaking the research, I felt that because I was doing quite a comprehensive kind of overview, that staff didn't actually capture what the people that were running. So that's just why I refer to them as facilitators. So I think that in regard to the support that people have got on the programs, it varies from program to program. I think that some programs will provide a lot of support for the people that are running the services, and like in any sort of service, that probably differs from across programs. What I would say is that ensuring that the client's needs are met is really important, and it's something that's come up a lot in the qualitative interviews, in the last interviews, and there were concerns particularly in terms of like the green prescribing pathways, that people might be prescribed onto programs, and are we sure that actually their needs are going to be met on the program? So if I'm talking about people who have experience with drug or alcohol use, then are the people on the programs actually able to support that. So even, for example, in terms of being trained in things like naloxone or trained in things like CPR, things like, so you've got two things. You've got the people who are on the programs that are potentially the support workers. Are they actually able to provide the support for the people of the program and the client's needs? But on the other side of things, the people who are running the activities, so if it's in wilderness, for example, have you got the or gardeners is the example that you gave, that are actually skilled in that area. So you really need like a multidisciplinary team. It's really unlikely that it's going to be sort of just one, like a person with all that expertise to actually like ethically provide that support for the person. So I think just opening up those lines of communication between like the GP and the people who are referring the people onto the program, just to ensure that they are going onto that program and they will have their needs met in terms of what they're looking for, and that people feel, so that the clients are safe, so that the facilitators as well feel that they have the skills to provide what they're wanting to provide. And then in terms of staffing and buy-in, and how we how we get people to buy in. I mean, you said it yourself. I wish I had that answer, because I think that it'd be. I think a lot of people want to know the answer, but I think that talking about buy-in from the GPs. So I think, again, communication is really key. I know that there's work being done by the Green Health Partnerships where they're actually going around GPs and speaking to them, and actually really putting emphasis on primary care or health professionals taking part in the programs themselves, or actually going out into green spaces, so that then they understand like the green space process a bit better. But I think that what research really needs to focus a bit more on is trying to integrate this like qualitative research into it, because we have a lot of quantitative data. We know that nature works, but what we maybe don't have is that sort of really rich client experience and that really rich client voice. And I think that that's really powerful. But yeah, there are limited funds available, and everyone wants their program funded. So I think like this goes back to where my work is sort of situated. This is why we really need to understand these mechanisms between it, because if you've got a program that is going to support people with problem substance use, but reducing substance use is not actually the outcome of the program, it might be a by outcome, but it's not actually the outcome. That's difficult to explain to funders. So you actually have to really be clear about what the wider outcomes are, what are the mechanisms, like why programs are important. And this is why sort of building this sort of framework to provide this kind of really rich understanding of the key processes within programs and what they can actually achieve and how wide ranging the benefits can be. That's why sort of it's so important. But there is a lot of work going on now in terms of buy-in. So down south, they've just released a paper by Karen Husk and colleagues down in Exeter. They've written a paper about green social prescribing and like buy-in and the processes within buy-in, so client buy-in as well. So it's certainly an area that people are really interested in, and the research is developing. And so it'll be really interesting to see how that's sort of developed, to just ensure that, or try and promote that buy-in a little bit more than it is already, because people get it. It's one of these things that's really grown in popularity, but it's a move away from the more medicalized model. And I think sometimes that presents a barrier. So that was quite a long answer to your question, but hopefully I answered it.
Thanks very much, Wendy. So if I can move on to, yes, you've just unmuted yourself, I'm afraid. Can you introduce yourself, please?
Yes, thanks, Lindsay. My name's James McDade. What you're actually seeing on the screen is my username from my work login. I'm with NHS GGC Greater Glasgow and Clyde Health Improvement Team here. I'm based in South Glasgow, and I was just wanted to kind of. I was thinking, a couple of times recently, and we've been involved in supporting people in recovery from addictions or dependency, whatever you want to call it. the fact is that, you know, what I notice very often in regards to green space in nature is that we tend to kind of talk about nature as if nature's kind of something else, if you see what I mean. Whereas I think, you know, that touches on a fundamental truth, like Wendy's work touches on a fundamental truth that, you know, that as human beings are actually part of nature, you know, and while the built environment is very useful, you know, at the same time, that I think that the more we lose touch with nature, the more we maybe suffer for that, you know, and I don't think that we always really acknowledge that, you know. We kind of categorize, you know, nature as something we maybe go to, you know, for a walk in the park. But what I wanted to touch on as well was the, you know, the holistic aspect, and, you know, I think it's Wendy made it clear there, you know, that it really has to be an holistic approach, that, you know, just putting on programs where people, you know, can link in with nature on its own. And just wondered, you know, does Wendy think that this maybe strengthens the argument for, in terms of alcohol and substance problems and dependency, does this strengthen the argument for, you know, good quality residential treatment services where people can have that truly wraparound holistic service where they are living within a therapeutic community? You know, I'm saying this is because I'm somebody that's been through that experience good number of years ago, 25 years ago. But, you know, part of that treatment experience for me was like being able to get taken away from the environment I was in, because I think a lot of deprived areas, you know, I think the view is these days that people should remain in their community, as what we call their community, in order to recover rather than being taken out of it. However, in a lot of deprived areas, I really feel that a lot of, you know, people are in the communities or in the places that they're put into, because, you know, very often people would lose tenancies, get moved to somewhere else, move to hostels, through hostels, the whole thing. And they don't necessarily feel that, you know, that is their community. You know, so taking them out of that into a place where they can get a truly holistic service. You know, when I was in treatment, you know, I was able to do things like orienteering, skiing, abseiling, canoeing, archery, and we also maintained a vegetable garden, and that was part of, you know, it allowed us to link in with these activities under guidance, in a safe place, and also have time to do the kind of psychological and emotional work that needed to be done. You know, I just find that, you know, that the community approaches, I think, are very useful, but I think they may always tend to be a bit bitty. You know, running programs start and stop. You know, this type of thing. I found that, you know, my time in residential treatment helped me kind of find my feet in order to come back to kind of real society. So I was just wondering if Wendy actually has a view on that. Thanks.
Yeah, I think what you're saying is very valid. I think that actually you see quite a lot of these types of programs in residential settings, for example, like therapeutic communities. And I spoke to a few people who have worked or are involved in working in those types of programs. And it's really interesting what you say about that idea of a little bit of a window out of that sort of that area, because I think so. One of the people that I spoke to was saying that sometimes they can do very, very difficult work, you know, in their treatment, and then the nature side of things, although it's so beneficial, it actually feels like just a step away, like a breath of fresh air away from that kind of the treatment approach. But I guess going back to what I was saying before, and what Serge was saying, that, you know, how do we support people afterwards? You know, how do we, and you mentioned that sort of idea of being a bit bitty, like, you know, how do we ensure that continuity of care? And I guess that is where we have that, when it's essential to kind of think more in terms of like partnership working and how people can come out of these therapeutic communities and how they can then be involved in, I guess, community groups that are available and what's available, and just being more transparent about what is there to support people, and making sure that there's kind of that more linked up approach as well. Yeah, I hope that answered your question.
Thanks very much. We are just coming to time, so I will go to, is it Brian, Bob or Brian Duncan?
It's Brian.
Duncan,
Yeah.
Brian Duncan. Please go ahead, Brian.
Thank you. I will try and be as quick as I can. I've kind of been aware there's so many strands to all of this, and I suppose part of my question at the end of that is about where next for you, Wendy. But in looking at some of the things that have come up for me, one is exactly what you were just saying just now. So I'm part of the project that Jill, who spoke a little bit earlier, was mentioning, branching out in South Aberdeenshire. And with a 12-week program, I work with Alcohol and Drugs Action in Aberdeen. And so I do some of the therapeutic kind of work, whereas Jill runs some incredible scientific workshops and craft skills things. But sometimes it's not till 6 or 7 weeks before some underlying stuff bubbles to the surface, and we're finding out and that people are really beginning to trust and open up, and that kind of environment allows a different type of intervention to actually happen than might happen in an office space. And I think that's really important. And one thing that we do have is that kind of multidisciplinary. So we have somebody from a community mental health team. We have somebody from a substance use service, and we have people whose expertise is in the forest and in identification and conservation. One of the struggles that we've had is about buy-in from the people that we want to refer to us. We have one GP who regularly refers in, and we've contacted dozens of them. And we find that quite bizarre, why is that? And the last thing for me is just about, I wonder, when I'm asking you what's next for you, is about, it's more than just what are we saving the NHS, which I think that we are directly. I mean, we could talk about a couple of cases specifically that where we've most definitely had an impact, not just on the individual, but on their family, on the community, on stigma in the community, and made a saving to the NHS by reducing the amount of, and probably the criminal justice system as well. On the amount of medication that they require. So at the end of all of that, the question is, I kind of heard you kind of saying, this is where you've got to so far, and I'm hoping that you're going to go off in and do some more research somewhere.
Yeah. So just to answer your question quickly, I know we're at 2:00, but so as I mentioned in my talk, one of the things that I'm really interested in doing is incorporating client voice, because I've not been able to do that because of COVID, and that's something that is really important to me. And I think that will help start drawing that gap, or like bridging that gap between what is it like, what allows client buy-in more, because actually we can talk to all the professionals in the world, but actually talking to the clients themselves and talking about sort of, what they want out of programs and what the pathways and sort of buy-in and engagement are, I think is really important, and can really only be gained from the client voice themselves. Going back to what I was saying just a little bit earlier in answer one of the questions, one of the papers that's just been written by researchers down in Exeter, so Karen Husk, and I don't think he's the lead author, I think, but if you had a quick look in on the University of Exeter's site, I think it's the European Centre for Human Health, for Environment and Human Health, so they'll have it as one of their most recent documents. So they've done a large amount of work in client buy-in and what is the most important aspects, and like how do we best address the challenge of getting clients onto programs. But I guess what they're focusing on in Dundee, like I said, is kind of going around and speaking to GP surgeries, like physically going around and speaking to them, trying to get GPs involved. I know they're very busy, but actually taking part in programs and actually taking part in sort of green health activities themselves. When they've done that, they're much more likely to recommend green health activities to other people. I guess, that's maybe not surprising that once they experience it, it's more convincing to them rather than that kind of like theoretical knowledge base. But of course, time is an issue, resources are an issue. But I would say go and check out that paper, because it is interesting in terms of thinking about client buy-in and what's important mechanisms for that.
Thank you very much, Wendy. And I know we have more questions lined up, but I'm afraid we're now over time, so I'm afraid I'll have to wrap up for this afternoon. And I think the level of engagement today has just shown how interesting people find this area, and that there is a lot more work to be done in it. And I think we've had some really interesting discussions. Yes, I mean, I think plenty more research to be done here. So I mean, it just falls to me. I mean, I can see Wendy very kindly has put down her email address for anybody who's got any questions. So that's just in the chat just now if anyone would like to get in touch with Wendy. But I mean, just to thank Wendy for a really fascinating presentation and discussion this afternoon. Thank you very much, Wendy, that was fantastic. And to thank really everybody who's been joining us over this year's kind of series of alcohol occasionals. We had a bumper run. We had 6 different alcohol occasionals this year because we had so many excellent proposals. And I think, the numbers of delegates who have been attending have, really shown how engaging people find these events. And it's fantastic to see so many people here. So it really just falls to me to say there will be a new run of alcohol occasionals beginning from in the new year again. We'll have a theme and kind of call for presentations and so on in due course. So keep an eye out for that if you're a early career researcher. And thank you very much, and enjoy the rest of your day. And we hope to see some of you again at one of our events.